I'm going to be live on YouTube also. Okay.
Mm-hmm.
Perfect. So I do believe that we are ready to share it. Okay. So let me admit the others inside of the application. I do believe that we are ready to share it. Okay. So let me admit. Okay. And there we go, admitting all. Perfect. So I have to switch them all. Stopping the video from the others, and I'm muting the others also. Okay. I have to mute the others to be able to start. Okay. I cannot see you now.
Okay.
Are you there? Yes. Okay.
Yes.
So good afternoon, everyone. Welcome back. Special occasion that we have the pleasure to have Zheng Liu, who is a part of the Tongji Hospital. It's a Tongji Medical College based on Wuhan, and I requested from Dr. Zheng Liu to talk about the perspective and the viewpoint of an ENT doctor in during this pandemic season of COVID-19 in Wuhan. So good morning, Zheng. Sorry, it's probably late night in China.
Yeah. Thank you. The invitation from you, the Pura, and Dr. Mobaraki. Hope I pronounce the correct. Yes, thanks for the invitation. So it's my very great pleasure to share you our experience in Wuhan, China. And as you know, that the Wuhan is at the epicenter of the break of the COVID-19 in China. And we also know that our Italy colleagues do very well during this pandemic. So we think we have a lot of the experience to share with each other to control this pandemic and from the efforts of the ENT doctor. Okay.
I think that you're right. One of the first nations that faced the emergency were actually China and then Italy and then spread worldwide. So what I would like to ask you is now that 2 months and a half passed, are you still facing emergency? And could you explain us what happened during the first weeks and in China, especially in Wuhan? How was the feelings, and how did you started to treat your patients or the people surrounding yourself?
Yeah, actually, at the end of the January, that's I think that at the end of the last year, the December of the last year, there are emerging of the very special of novel pneumonia patient in our hospital, but we do not know much about this. And those patients were isolated in the department of the respiratory medicine department, and then later they were transferred to the designated infectious disease hospital in Wuhan. But at the middle of the January, and more patients coming to the fever clinic of our hospital. And at that time, we do not have a great ability to do the RNA test at that time. So most of case cannot be give the accurate diagnosis at that time. And then at the end of the January, that we have the RT-PCR test in our house, the kits in our hospital, and we can do the RT PCR test for the older patient that come to the fever clinic. But at that time, that a lot of the patients, they are overwhelmed the fever clinic in our hospital. And then we realized the very bad situation, and then our hospital and opened, how to say, reallocate more beds in the infectious disease department to receive those patients. And we also to enlarged the area of our fever clinic. And then the physicians in the ENT department were recruited and to be trained to the knowledge of the COVID-19, and because we need a lot of the physicians in the fever clinic. So we recruit our physicians in the ENT department to go to the fever clinic, to go to the front line to fight the COVID-19. But for the specialty of the ENT, that at the middle of the January, we do not have a lot of idea about this disease. So at the middle of the January, we do not have a very strong protection for our ENT doctor. But fortunately that we do not have a lot of infected our colleagues in our department, And maybe because we are lucky enough, but as I know that in other hospital in Wuhan city and in their department, they performed a laryngoscopy surgery for one patient, and later this patient was confirmed to be the patient with COVID-19, and this patient infected the medical staff of the ENT department, about I think about 3 doctors and 3 to 4 nurses. But in our hospital, we are lucky that we do not have the very serious infection. Yeah. But the situation is become much better now. Yeah.
Do you have the possibility to switch between the slides? Can you show the other slides? You just you can skip between them.
Yes.
So let's start with your presentation and let's figure out what were going on, what happened in China and Wuhan.
Okay, thank you. So I will go through the slides. So as you know that the first case of the COVID-19 was reported in Wuhan, China at the end of December 2019. And till now that we know that globally there are more than 3 millions of the patients suffer from the COVID-19 world around. And so it's a very serious public health issues. And for Wuhan, that it was knocked down in the January 23, 2002. So we shut down the communication of Wuhan with the other cities of China and other cities of the worldwide. And at the April 8, 2008, about the 2 or 3 weeks ago, that because the situation is much better now in Wuhan, so the Wuhan was reopened. And in Wuhan, that we have that until the April 27, that we have the 15,000 confirmed cases of the COVID-19, and about 46 cases have been recovered. About 3,800 patients have died in the city of Wuhan. So the mortality rate in Wuhan city is over 7%, but it was about 1% in the other cities or areas in China outside of the Hubei province in China. So the Wuhan is the capital city of the Hubei province. And we have the data that at the end of the March of the 2020 in China, that there are more than 3,000 healthcare workers have been infected by the SARS-CoV-2, and among them, about 22 healthcare work has died. And we know from the news press that it seems that more than 5,000 healthcare work has been infected in Italy. So I don't know that whether this number is correct, but I get this figure from the news press. And we know that the healthcare workers in the otolaryngology hand and neck surgery department, in particular, have the very close contact with patients' nasal and oral secretions. So we are theoretically more vulnerable to the SARS-CoV-2 related infection. And Tongji Hospital is one of the biggest, largest hospital in the Wuhan city, and we have 5,600 beds, inpatient beds in our hospital. And during this outbreak, we have reallocated more than 2,000 beds for the treatment of the COVID-19 patients. And in our department, all the elective surgeries have been canceled during before the April 8th, during the lockdown of the Wuhan city. And we only did perform the urgent surgeries during the outbreaking. And trivial to the emergency surgery, it's generally impossible to conduct the SARS-CoV-2 screening very carefully. So we should do very careful precautions for these emergent surgeries. We reconstructed our wards and the clinicals to meet the requirement of the infectious disease control. So we reorganized our wards into the 3 areas and 2 channels. The 1 channel for the patient, 1 specific channel for the doctors and the nurse. And we said that the buffer room between the contaminated area and the semi-contaminated area, and also the buffer area between the semi-contaminated area and the sterile area. So we reconstruct our ward and our clinic. You know that we are the comprehensive hospital. So the original design and the construction of our ward and our clinic is now cannot meet the requirement of the infectious disease. And this picture is taken from a paper published in the New England Journal. And we can see this picture showed the fluorescent dye expelled from a simulated patient cough that ended on the face shield of a laryngoscopist. So we can see that the ENT doctors are at very high risk to be contaminated by the airborne droplets transmission of the virus. And in China, that we have the 4 degrees of the precaution for the airborne infectious disease. We have the basic precautions. It means that we wear the work clothes and the surgical masks. For the grade 1 precautions, we wear the medical cap, surgical masks, and we wear the gloves. For the grade 2 precaution, and we wear the N95 medical protective mask, and we also wear the protective clothing, and we ask to wear the anti-fog, the goggles, or the protective face shield if there is a risk of the transmitting of the viral droplet. For the grade 3 precaution that we used, besides, in addition to the grade 2 PPE, the personal protective equipment, and we add the comprehensive protective face shield and all the poured air purifying respirator, the PAPR. And this picture shows the basic precaution that we wear the work clothes, the surgical mask. And this is the illustration for the grade 1 precautions. So we wear the cap, the surgical mask, and also the work clothes. And that is the grade 2 precautions. So we wear the protective, the gown, and we wear the N95, the masks, the protective masks, or sometimes we wear the face shield or the protective goggle. This picture shows the grade 3 precautions. So we either wear the comprehensive protective face shield, or we wear the PAPR for if we do the tracheostomy, that we need to wear the PAPR because it can give us more clear visual field. And for the comprehensive, the protective face shield, sometimes it's not so friendly because when you do the surgery, the position of the face shield can move and it can mask your visual field. In our clinic, so we use the grade 2 precaution in our outpatient clinic. So in our laryngoscope room or endoscope room, we use the grade 3 precaution. For the wearing and the remove of the PPE, that every physician and nurse should receive the very careful and proper training before they go to the clinic or go to the isolation room. And all these processes should be closely supervised by the dedicated infection control nursing staff, and those nursing staff are well trained by our hospital infectious control department. And this is the suggestions published on the JAMA Otolaryngology-Head and neck surgery. And so you can see from their recommendation from the American, and it's quite similar to what we are doing in our practice during the pandemic. And you can see that if you do the intervention procedure, you use the 95 masks. But if you do the aerosol generating intervention procedures, if the patient have the active SARS-CoV-2 infection, then we need to wear the PARP and N95 masks, and we use the double gloves, the gown. So it's quite similar to what we are using in our daily in our practice during this pandemic. So you can see that is our outpatient clinic during the pandemic. This is the patient. This is our ENT doctors, and it's well the protective gown and well the 95 mask, also the face shield. And this picture show you the physician's PPE during the nasopharyngeal laryngoscope, and you can see it's grade 3 precaution. Our physician also wear the comprehensive face shield. So we do a very critical screening and treat in our outpatient clinic. So we have isolated fever clinical in our outpatient department. So at the entrance of the hospital, also at the entrance of the outpatient clinic, and also at the entrance of the specialist clinic, the patient will take the temperature measurement. So they have the 3 temperature measurement before they go into the specialist or clinical room. If they have the temperature higher than the 37.3 centigrade degree, and then the patient will be guided to the designated or isolated fever clinic. In the fever clinic, the patient will be given the COVID-19 screen. If there is no fever, and then the patient will go to the ordinary clinic. So if a patient want to do the surgery, for example, if at that time during the pandemic, we only do the urgent surgery, but after April 8th, after reopen of the Wuhan city, and we provide our ordinary medical supplies to the citizens. So we start to do the tonsillectomy, the endoscopic, nasal endoscopic surgeries now. But before the admitting of the patient, we do critical screen before the admitting. So first, the patient should not have fever, should not have obvious indications for COVID-19. If the patient have fever or some sign of the COVID-19, that patient will be guided into the fever clinic to do the screen. If the patient have no fever, have no signs of the COVID-19, then we will give the patient the screen in the outpatient clinic. It includes the CT chest scan, the nuclear acid test of the SARS-CoV-2, and also the antibody test. If they are all normal, there is no abnormal, then we will admitted the patient to the hospital, but the patient will be put in a buffer area in the ward. It means that in the buffer area, only one patient in one single room, and the patient will end very close management and monitoring. And after 3 days, and in the buffer area, our physicians and nurse will take the grade 2 precaution. 3 days later, we will do the CT chest again, also the nuclear acid test again, and antibody test again. If they are all normal, then the patient will be transferred to the normal area. And in this normal area, and can be 2 patients in one room. And also our healthcare workers will only take the grade 1 precaution, grade 1 precaution. So if the patient in the buffer area, if they want to do a surgery, and in the OR, in operation room, and our physicians, our surgeons also take the, and the attending nurse also take the grade 2 precaution. For the patient in the normal area, if they do this, if they receive the surgery in the OR room, our surgeons will only take the grade 1 precaution. And for the tracheostomy, that we do have some experience, but our primary experience are based on the previous experience that has gained during the pandemic of the SARS. And there are some publications regarding the tracheostomy for the SARS patients. And we can see that in this case series, that it suggests that the tracheostomy should be either be done in the negative pressure room in ICU, or the single room in ICU. That also that's advised that the dedicated team or the senior attending team should do this tracheostomy, and so also that the patient should be completely paralyzed. And for the protection, that the surgeons should use the standard PPE and also have the PAPR, also the PAPR. And so with the based experience that gained from the SARS, so we do the tracheostomy for the COVID-19 patient that basically relied on those experience. And that is our colleagues are doing and did the tracheostomy for the COVID-19 patient. And this guy is the guy in the ICU department, and they help us to monitor the patient's condition during the tracheostomy, and also help us to take off the tube during the tracheostomy. And our doctors will the PAPR in the tracheostomy. So before the operation, that we should assign the skilled surgeons for the tracheostomy of the COVID-19 patients, and all the surgeons and the staffs in the room should be trained well in wearing and remove of the PPE, as I mentioned before, and also besides. We did the tracheostomy majorly the bedside for our patient in order to avoid the transport that may facilitate the error transmitting. And during the surgery that we should completely paralyze this patient in order to reduce the aerosolization, and the mechanical ventilation was stopped before the tracheostomy, no suction during the procedure, and to be avoid diathermy. After the operation, that's the Department of the Nosocomial Infection Management should take care of the disinfection, and all the medical staffs in the room are reminded to be careful of the potential of the occupational exposure, and they should report their health condition to the staffs in the nosocomial infectious management department. And in our experience, there is no complications attributable to the open tracheostomy, and all of our surgeons and the staffs during the perform of the tracheostomy are kept in warehouse, do not have the infection of the COVID-19 in a follow-up period of at least 2 weeks after surgeries. And we know for this tracheostomy, we also lead the multidisciplinary collaborations. And before the tracheostomy, we should notify the ICU staff and also the infectious control staffs before the surgery. And because we have a lot of the very critical ER patients in our hospital, so we do not have so many elective pressure rooms to accommodate those critical ER patients. So some patients are treated not in the elective pressure room. If they need to receive the tracheostomy, and we try to use the I try to use the high powerful fine to generate a relative lactive pressure in the room. So the mechanical ventilation was stopped before the tracheostomy. So after the tracheostomy, as I mentioned before, the Department of the Infectious Control Department should take care of the disinfection. Okay, so this is my experience that I want to share with our colleagues. So thank you very much. Thanks.
Thank you, Zheng, for your presentation, which lead us to understand exactly what's the situation in there. And it's very important to remind that the pandemics is changing worldwide, and the relationship that should be proposed worldwide should be also pinpoint. I think that every day should be done, but however, it's not so easy. You know, everyone is facing the emergency. Before China, then we had Italy, but now it's spreading worldwide. As you know, we're facing the emergency phase 2, which will lead from May 4th to a reopening, or at least a partial reopening of the borders of each region. Of course, this has an economical issues and difficulties that should be faced. So as far as I understood what's happening in Wuhan and in China, the reopening led to a re-changing of the curve with more infection. So as you know, everything changed in 2 months, and we do believe that we're prepared for a new. Of course, we have to take in mind that we are facing a new emergency, but this time we should be, you know, prepared for that. At the beginning, what we were facing was just, you know, everything was new. We weren't able to have ICU units, which something that we have right now, and the potential is changing. So the next and the future is going to be the challenges for having vax, boosters, or
Yes, yeah.
drugs. I don't want to go in details about what's the treatment of this disease. As far as everyone knows, what's figuring out right now is not only to having vax or boosters, but it also, the use of drugs and pharmaceuticals equipment, something new that wasn't able to be done before that. As you know, everyone is facing the emergency using all kinds of drugs, not only built for this disease, which is new. We are thinking about, for example, chloroquine. Many people are thinking about as a prophylaxis, but at the other side, we already know that chloroquine and azithromycin are causing heart failure and diseases.
Yeah.
So do you think that what we should be focused now on is not only what kind of drugs are going to administer, but as ENT doctors, what we are facing is to understand that our approach against this disease and for those patients should be completely changed. How would you think that in the future the our clinical activities would change? As you know, we are one of the most one of the specialists that are going to face the emergency from the beginning. Because we are treating oral patients, larynx, nose. How would you? Is there any thoughts from yourself, or is China facing the new emergency, thinking about like one-time usable endoscopes or sheets, or do you think that anything will change in the next 2 months?
Yeah. Thank you for your question. Yeah, that is a very it's like kind of the imagine the future. Yeah, it's very good question. That I think that the disease or the outbreak of the in COVID-19, I think it can surprise or inhibit a lot of the requirement of the medical service of the patient. I mean that patient may not go to the hospital if they have mild disease or have the mild symptoms. Like that's one point. They may not go to the hospital. They may to endure by themselves. That's one point. And the other point that as you mentioned, that maybe we go to the a lot of the people are trying to do the virtual clinical, and we use the internet to do the consultants for the patient, but it's kind of difficult for the ENT doctors, because most of times we need to collect we need to collect the pictures or the physical changes of the nose of the or the larynx. So as you mentioned, maybe in future we can use the one-time laryngoscope like this, but it's also very challenging, because it can increase the cost of the medical supplies. Yes, it can increase the economical burden of the whole system and of the patients. And in China, that after reopen, I don't know whether it's also the issues in the Italy, that in China, like in China, after reopen in Wuhan, after reopen of the city, actually we've also faced a very difficult questions about of the management of the hospital. So how can we make the hospital can run smoothly? You know that if there is no patient, if we do not provide the medical supplies to the patient, and there is no income of the hospital, yeah. So it's also a very big challenge for the hospital to go run smoothly. But I think for the ENT doctors, because we rely a lot of on the physical examination, right? So I think it's still a big challenge. So maybe I cannot give a very good answer to to your question at the current point. Yeah.
I think that what you were saying was right, And due to the limits of time, I would like to ask you the last question. However, as I'm always saying, for any other questions, please, I do believe that Professor Zheng Liu will be able to, share his thoughts. And if anyone is going to be interested, could contact him directly on email.
Yeah, yeah.
What we want to do today is to have a point of view from one of the ENTs that faced the emergency from the beginning, and to see what changes in 2 months. And the last question is this: um, what's the attitude of Wuhan? I cannot tell about China, but what about your point of view, or what's happening over there? Are you facing the possibility to test, instead of having a nasopharyngeal swab or oropharyngeal swab, just to provide serologic tests? Or do you believe that a combination of those two will lead to a better chance to recognize the disease, both in terms of qualitative assessment and quantitative, which we know that serological tests will provide more about qualitative test if we do it with a skin test, or if we do serological tests from the blood example, we'll see quantitative. At the same time, what about the nasopharyngeal swab, which led and progressed to reaching a lots of false positive or false negative? Usually false positive will not be able to be detected. The problem is the false negative. So
Yes.
from your point of view, and from your sets right now, do you think that the emergency should be faced through an increased amount or numbers of swabs and serological tests, or one of the other?
Yeah, I think it's very, 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 very good questions. Yeah, yeah. I think that the serological test and the swab test have different functions. So if you want to confirm the disease, confirm the pathology, yes, if you want to confirm the current infection of the pathology of the virus, you have no choice. You have only one choice to do the RNA test. You need to do the nasopharyngeal swabs. If you have the positive test of the IgM or IgG, that you cannot see that that patient is, I think that you cannot have the very confirmed diagnosis of the COVID-19, because for the serological test, you may have the false positive result, right? So it may have the cross reaction with the other virus, coronavirus, or the coronavirus, most likely the coronavirus. And that's for the serological test. It may have the false positive result. For the leukemia test, the biggest problem is that the leukemia test, they have a very high rate, as you mentioned, they have a very high rate of the false negative results. So you need to do repeat. If you have one time of the negative result, it cannot preclude the possibility of the infection. You need to do the second time or the third time to confirm, to have a confirmed diagnosis. But if we do the serological test, we do have, if we use this test, we can have some idea about the, how to say, about of the asymptomatic infection. For example, if the patient have increased elevated IgG levels, but that do not and never have the symptoms of the COVID-19, that you can confirm the frequency of the asymptomatic infection due in the whole population. So I think that serological test can help us to recognize the asymptomatic patient, and also the response of the immune system of the whole generation. But if you want to confirm the diagnosis, I think the only one test is the nuclear test. For example, if the patient have a IgG, if the patient have a positive IgG test, if you want to preclude the current condition of the infection, you have to do the nuclear test again, right? Yeah, yeah, that's my idea. Yeah.
Well, just to conclude, before telling the others a new appointment that we have, first of all, I would like to congratulate you because we deal with this topic very quickly. I had the possibility and the option to be with you on a panel a few days ago, worldwide stream, and I'm very glad that we had this connection. The thing that I would like to point out is that right now it is mandatory to have nasopharyngeal swabs worldwide. First, different modalities that should be announced are not only hospital or go home. A drive-through would be great, but we do have to keep in mind that if we just select the people that we want to propose the nasopharyngeal swab, it will not the whole thing. I do believe and I do suggest, and I think that everyone will be in accordance with me, that if we do a massive nasopharyngeal swab, so at the same time, simultaneously, we will put everyone in the isolation, and we will try to isolate as much as we can the virus. Otherwise, we cannot figure this out. It's not just the time for thinking about strategies of drug therapy and others. The isolation will be one of the greatest emergency or the procedure that should be done. Second of all, there's tons of debates on nasopharyngeal swabs. Many people and many authors, statements about how to do it. It's very important because we have to keep in mind that the World Health Organization before March 18 wasn't recommending the test. It was huge. What happened was completely insane that before 18 of March, the World Health Organization didn't recommend it to do the test, but I remember clearly that between 18 of March, the World Health Organization declared to do test. However, we still have to think in mind that worldwide is not the same. We will see and face the problem in countries or nation or continents that are not ready for that, and we have to think about that too. So thank you, Zheng, for being with us today with your explanation. I would like to have you once again in the next future, or maybe a month, to see what's going on in there. The situation in Italy, as I already said, it's declaring the phase 2 from the 4th of May, and then from the 18th of May will have a huge impact of economical assessment. And we need to also think about the psychological effects that this whole viruses had on economy and on health states. And regarding to that, I would suggest anyone to attend May 1st. I will have a special contribution as a guest from Zara Patel. We first were supposed to have a talk regarding olfaction. We organized a few months before this topic. However, I was convinced to change a little bit the topic, because at the beginning she was supposed to talk about therapeutical option for treating patient with olfactory loss. But now, since the pandemics and the situation regarding the COVID-19, the so-called anosmia and algesia is an emergency, and we will talk about that too. So thank you, Zheng, for being with us today, and I really appreciate that, because today it's I think that almost 1 o'clock in the AM in China. So thank you again for being with us, and I recommend everyone to attend the first May meeting. Thank you so much, Zheng. Goodbye.
Thank you, Pura. Thank you very much. Thanks.
Bye-bye.